Yes. Okay, so thank you so much for inviting me here today. I am a medical anthropologist, and I'm with George Washington University. I also have a day job with the government, so I can tell you that my views that I'm expressing today are based on research that I did prior to being in the government and have nothing to do with what I do in my day job. But what I want to do is provide a different perspective that I haven't heard today. And when I first came into studying euthanasia and end-of-life care, I went to the Netherlands and I noticed that there had been quite a number of studies that had been done that were interview studies, sometimes interviewing professors, doctors about euthanasia deaths that had occurred sometimes, months or years previous. We also had seen, some good epidemiology studies giving us the stats on what numbers of people were doing what. But what I did not see, and there were only 2 ethnographies prior to mine that came out in 2009, but there'd only been 2 studies that had gone out and basically done observation. So my purpose today is to take you into the home. Let's get out of the law. Let's get out of the hypothetical. Let's move away from opinion studies and get to what euthanasia looks like in practice day after day after day after day. And I can tell you that what I found when I went there was not what I expected. I thought I was going to study death and dying, and I instead found that I was studying something quite different. So, which button do I press? The obvious one. Okay, so my aim today is to talk a little bit then about what Dutch euthanasia looks like in practice, and I am talking about euthanasia. This is, I've heard it referred to today as physician-administered aid in dying. We are not talking, I'm not going to be highlighting physician-assisted suicide, which is what the Dutch call it there, because that is a practice that they don't do that often because they find it tends to be unpredictable. People don't die as soon as they take the pills, and Dutch doctors and families who live there find it unpleasant, so they tend not to do it. They go euthanasia instead. I'm also going to talk about the difference between law and practice, focusing on the practice, and then see if we can't pull some lessons from the Netherlands to talk more deeply about physician-assisted dying here. Okay, so this is based on a study I did a long time ago, back in 1999 through 2001. I spent 15 months sitting with people who were dying. I would work with their general practitioners, and depending, I had a number of practitioners in the city of Amsterdam, and another half of my practitioners were in a cluster of small towns outside. And I would spend every day sitting in the office with the different physicians, and then we would go on house calls where we'd see their more serious and end-of-life patients. And through the house visits and the in-office visits, I would meet their end-of-life patients, and I would ask if they'd be willing to participate in the study. So over the course of my time there, I met approximately 650 general population patients, and 192 of those are people who I would consider potential target for me, which were serious chronic illness, end of life. And then out of those, I basically sat with day after day after day, went back and back. I did interviews with their family members, with them if they were still able to speak, sometimes with home health, with their physician over and over again. And so that was the bulk of my original study. 2008, I went back again and did some follow-up interviews with some of the family members and some of the doctors. And then in 2012, I did a slightly different study looking at long-term care and some of the innovations there. So this is what my talk today is based on. So it is data that really describes something from a time past, but I do know anecdotally, continuing to talk to my colleagues, and I have people who reach out to me on occasion that they feel that some of the same things that I described back then are occurring today, but we'll see. So first of all, I want to start off with a story. This is a real story. The people in the story are real. The words that I am quoting are real. The photos I pulled from the internet because I'm not showing. I gave anonymity to the folks in my study. So these are just to illustrate the story that I'm telling that is actual. Also, the names have been changed. So mevrouw Verhoeven is age 80. She had been receiving treatment for breast cancer that had spread to her lymph nodes. At first, the pain was manageable, but over time, she could no longer eat with her husband anymore, and she couldn't get outside in her garden, two things that were important to her. The pain got worse, and approximately 1 year after her terminal prognosis, she asked her doctor for euthanasia. It was tough, but a significant case for her doctor. One, because mevrouw Verhoeven had had a fight with her adult daughter many years before, and even though they lived only 3 doors down from each other, the daughter had not spoken to her mother in 15 years. Dr. Janse was a general practitioner to both mevrouw Verhoeven and her daughter, and although she tried to get them to reconcile before her death, she was not successful. It was a significant case for the doctor also, though, because she connected with mevrouw Verhoeven in a way like family. When she asked for euthanasia, the doctor was shocked. She said, "I can't do this. She's my grandmother. Do you really want this?" she asked. "Yes." "Okay, well, I'll come back tomorrow." And then I came back, and I came back. That was the doctor. So Dr. Janse did what all doctors I met with in the Netherlands do after receiving a euthanasia request following terminal prognosis. And what she did is she scheduled family meetings to discuss the euthanasia request. The doctor tried to get the daughter to come, but without success. With mevrouw Verhoeven, her husband, son, and his wife present, they talked about why she wanted euthanasia now, why the suffering was unbearable, and what the family felt about her request for euthanasia. And like every family meeting I was in that occurred after every euthanasia request, after the serious one, basically we go around and we talk to each family member and say, well, what do you feel about the request? And if someone doesn't agree with it, then we talk more. That's how it goes. Dr. Janse met with mevrouw Verhoeven regularly in her last year and almost daily in her last 3 weeks. She sat with her for 2 hours once and heard her life story. The second doctor came out and verified that mevrouw Verhoeven's request met the requirements for due care, but Dr. Janse stalled the euthanasia when mevrouw Verhoeven her husband, expressed his wish to die with his wife. Dr. Janse wasn't going to do that, so she paused the proceedings for about 3 weeks, offering treatment for him and palliative care for her until they were certain that he wasn't going to commit suicide alongside with his wife. I asked the doctor, let's see, we bumped out of there. Any tips for how to get back in? Let's go. Oh. All right, I'm going to jump in. So I asked the doctor why mevrouw Verhoeven chose euthanasia, and she said, quote, "I think she was too old, and at first euthanasia was for other people, not for her. But then the idea came in her head, and she didn't want this anymore." Oh, goodness gracious. Okay, this is probably not going to work, so I'm going to skip it. Let's leave on a good photo. She didn't want to be completely dependent on her husband. She was in pain. She had trouble getting air because of the fluid in her thorax. We talked with her husband and son about it, and first her husband agreed, and then her son. Her grandchildren came, they said goodbye, and she was ready. So on the day of her scheduled death, mevrouw Verhoeven lay in a hospital bed on the main floor of her home. This is where many people are able to die in the Netherlands because of the extensive home care that's available. Her neighbor, her husband, and son were there. Dr. Janse told me about her last day. She said, quote, "She kissed everyone, and then she turned to me and said, 'Am I allowed to kiss you too? To give me a kiss too?' I don't know if you have this in English, but in Dutch we have the u and the je forms of you. U is for special and je is for friends. And she asked me, am I allowed to give u a kiss? And that was emotional for me. I asked if she identified with mevrouw Verhoeven like a grandmother, and she said, yes, I think so. I think that was my problem. When you're knowing that you have to say goodbye to somebody, you're not so afraid to get in close because you know it's ending. And with euthanasia, you come there every week, every day, so you get in close. If you have to continue 20 years, people keep a professional distance. I lose that in cases where people are dying. Okay, so let's talk about euthanasia. And let me see if I'll just try to jump it past. Probably not going to work. But basically what I found in the Netherlands, and I wonder if I could just use this. Do you mind helping? And just see if we can't get down to those slides without going back into the thing.
Yeah. Can you put it?
Oh, great. Anyway, I'm going to keep going. I'm on the euthanasia talk slide. So what I found was that euthanasia occurs in the Netherlands largely as talk. It's really mostly not about that final day. And that talk occurs over the course of years, sometimes months, and sometimes weeks. Now, the bias in my sample is because I was working with general practitioners, I was getting people who are in the domain of the general practitioner, so that means at home or in the nursing home. So they tended not to be the sickest of the sick. So they had time to process. So I don't know if it's a little different in the hospital. But what I found in my small sample, and I had 14 of my 25 case studies who had discussed euthanasia as an option, 11 who did not. And so over the 14, if you just look at that small sample, I had a number of them give the initial request. And then and the initial request usually comes, first time you might get a health scare, or maybe just to make sure your doctor is somebody willing to do euthanasia, because doctors have the choice too. They're allowed to say, I don't want to do it. And so that the initial request occurs, and then it might occur multiple times. Usually when somebody gets a little bit serious, they're going to put a written request in, but you can see I had a number of my 14, I don't know if you, well, leave it there, whatever. Number of my 14 drop off. And then very few, more than half my sample of 14, small sample, drops off when it gets to the second opinion, but when the independent doctor comes out to check. Because usually, by the time you're going to have the independent doctor come and see whether your request meets the requirements for due care, you're fairly serious at that point. But I still had folks drop off after that. And so a date would get set, and then finally euthanasia. And so I had 3 of my sample of 14 that I did intensive work with who died by euthanasia. And that's fairly typical from what I see when I look at the larger statistics. All right, so let's talk about law and let's talk about practice. And if you could maybe just bump it. Yeah, that's perfect. Okay, so in the law, the Dutch law has these requirements for due care. And the law focuses on a series of decisions and a series of activities. It's basically, illuminates the patient as a decision maker, and it really outlines a lot of the parameters. So it's voluntary, it's well considered, suffering is unbearable. It gives the physicians, their role and what they're supposed to do. There is no mention in the law of family, and there is no mention in the law of dialogue occurring over lots of time, and there's no mention in the law of physicians stalling after each of the informal stages of euthanasia talk, which is also not in the law. So there's no mention of all the stalling that occurs by the physicians, because they'll say, okay, well, now we have your written request. Let's pause a minute. How are you feeling today? When you're ready to go back to that, we can talk about it, but how are you feeling today? Okay, so that's what happens in the law. In practice, this is a long series of discussions occurring over years, months, weeks. Not so many actually die by euthanasia. The 3 main reasons I found for people not dying by euthanasia is a family member says, I'm not ready. I'm not cool with that. 2, the person will just decide over time and during a stall, they'll never restart the process again, because the onus is always on, in the Netherlands, the onus is always on the patient to restart the request. So after it gets stalled by the doctor, the patient has to say, oh, you know, I'm feeling worse. I don't think I can handle this. Can we keep moving this forward? And then that's how it goes forward. In practice, I got 3 minutes, good?
That's 3 over.
Oh, good God. All right. Well, all right. So in practice, the patient gets activated. They talk about what matters. The physician has a role when otherwise there'd be niks meer on to do, nothing more to do, is what happens when you get a terminal prognosis. There's a lot more to do. There's a lot of talking to do. There's a lot of connecting to do. And what I found, and I think one of the biggest findings from my study, is that what happens in this talk is social bonds get maintained at a time when mostly they're slipping. And it makes, I think what happens is people don't go through with euthanasia and they don't get to it because they have what they need in the dialogue that they're experiencing, and that's important. So finally, let me see if there's anything else I can throw out there as important. So let me just say, this is a, when you have a law, it is in the context of culture. So all these things that I'm talking about for the Netherlands is not something that you can uproot and transport to Oregon. And how Oregon practices it, and how Montana is going to practice it, and how DC, I don't know, it's going to be slightly different, but it's going to be based in US and local cultural ways of thinking, feeling, acting, and understanding, okay? So these are cultural processes, and it matters. And I'm not saying that you need to change the law, because law and practice is quite separate sometimes. I'm not saying that you need to get more prescriptive in the law, but when you ask the question about, is physician-assisted aid in dying, physician-assisted suicide, is it something that's appropriate for us here in the US? What we have to ask ourselves is, does it fit with us culturally, and how does it, and where does it not? And so consider the cultural context, and please consider that it is a practice that goes way beyond what you see in the law. Thank you so much, and I'm so sorry I went over.